So now we're going to talk about kind of the clinical management of using all these drugs in heart failure patients. And so this is kind of a nice diagram I got from a textbook, Coda-Himmel Applied Therapeutics. And essentially what they've done is they've taken the 4 stages of heart failure and they put kind of the common defining characteristics in the first box, and then they suggested which drugs and which therapeutic interventions would be most pertinent to treating that particular stage. And so, for example, stage A basically has a high risk of heart failure with no symptoms. And so the first thing that you should do is control risk factors, and that includes treating for underlying conditions, hypertension, diabetes, hyperlipidemia, and so forth. And then also lifestyle modifications, including alcohol cessation, smoking cessation, increased exercise, and so forth. And so in spite of treating these comorbid conditions, kind of the frontline therapy in the high-risk patient who's maybe kind of progressing from asymptomatic to maybe some minor symptoms will be the inclusion of an ACE inhibitor or an ARB. Okay, and so as you progress further now, a stage B patient, this patient has structural heart disease and they've got the defined left ventricular ejection fraction less than 40%. Okay, and even though they may or may not be symptomatic, basically we're going to continue with the ACE or the ARB, and perhaps we'll include a beta blocker. And so here it says titrated to the maximum tolerated dose. And so again, we're going to start low and then titrate until hypertension and some of these other comorbid conditions are well controlled. As the patient further progresses to heart failure, here in stage 3 we have now structural heart disease and we've got previous symptoms. And so in this particular patient you may be thinking they may have had an MI. Now they're starting to exhibit volume overload, which will be treated with diuretics. And that usually comes into play after salt and water restriction. Lifestyle modifications have been suggested. They're still on the ACE inhibitor and the beta blocker. If symptoms don't improve, now you'll start to see therapy including the addition of an aldosterone antagonist, some of the other vasodilators such as hydralazine or isosorbate dinitrate, and the inclusion in specific patients of digoxin, which we haven't talked about, but we will in a few minutes. And then, of course, as we progress into the final stages of heart failure, here we're starting to see refractory symptoms. And so refractory heart failure means essentially all these drugs that we've tried before now are not working anymore. And so now the therapeutic approach is going to be a little bit different. We'll start to include positive inotropes like digoxin much more frequently. We'll start to reduce the number of drugs that we've basically been keeping this patient on, and we're thinking in terms of, you know, cardiac transplant or left ventricular assist devices and so forth. And so we're looking at mechanical types of support because, you know, basically a lot of the previously controlled measures are no longer working. And so that's kind of the continuum of heart failure. And as you can see, we start with ACEs and ARBs, and then we kind of add on beta blockers, and then we start to add on diuretics, and then, you know, the aldosterone antagonists and hydralazine and some of these other drugs. And so that's kind of the general kind of approach, is that if you know what stage or class of heart failure your patient's in, you can easily make a short list of the drugs that you would expect them or they ought to be on. Likewise, here we're kind of comparing the stages of heart failure with the classes of heart failure from the 2 different staging criteria and how they manage it. So basically this table essentially summarizes the previous flow chart with what I just said. And then this also summarizes that as well if you're a visual learner. So ACE inhibitors are basically used throughout the progression of heart failure. Beta blockers may be delayed a little bit in terms of when they're initiated. Both loop diuretics and mineralocorticoid antagonists or aldosterone antagonists would be initiated as patients progress from stage 1 to stage 2 or class 1 to class 2. And then, of course, hydralazine and nitrates would be implemented later in the progression of heart failure. And and with emphasis on special populations such as African Americans or patients of African descent. It's been shown that hydralazine and isosorbide dinitrate really benefit these patients much more dramatically than a lot of the ACEs and the ARBs, but still part of therapy for all. So I like these kind of summary charts to kind of put things in perspective. When students are first learning this material, they're under the impression that they should be choosing one or the other. And it's not until much later in the lecture where they realize, indeed, they're on all of these drugs. These patients are on all of these drugs. And so that's kind of just different ways of representing that to make it a little bit more evident for you. This is kind of the same, excuse me, the same kind of concept here. You've got the different stages. And then what I've done is I've underlined the first incidence of where these drugs are first mentioned. And so ACEs and ARBs initially, followed by beta blockers, followed by diuretics, followed by the aldosterone antagonist. And then you can see the inclusion of digoxin basically as patients progress from stage C to the refractory stage D. And then at some point there's a line drawn in the sand, so to speak, where positive inotropes are implemented into the therapeutic treatment, and some of these other drugs are no longer needed. And so that's kind of where we're going to go with this next video, which is the end of the heart failure series in terms of the other types of heart failure. And so what we've been looking at for the last hour or so has been essentially systolic heart failure, and that's evidenced by and defined by a reduced left ventricle ejection fraction, so less than 40%. There are two other classifications of heart failure, and these classifications are treated differently. And so I just want to kind of introduce the topic to you so that you've at least seen it once and you can identify it in the near future. So we were talking about systolic heart failure, as evidenced by reduced left ventricle ejection fraction, and these are the drugs that we've just talked about. This is in contrast to diastolic heart failure, which is evidenced by a normal left ventricle ejection fraction and are treated with different drugs. Now, of course, some of these drugs are on the same list, and if you look at the mechanisms, you can possibly understand why that would be. But with diastolic heart failure, the main drugs or go-to drugs include beta blockers and ACE inhibitors, and the inclusion of antiarrhythmic type of agents, and also drugs that have the ability to block calcium channels. And so that's kind of the main short list of drugs for diastolic heart failure. Okay, and as we kind of progress through the different phases or stages of heart failure, I want to draw your attention to a special defined type of heart failure called acute decompensated heart failure. And so here we're talking where volume overload and really low cardiac output is presented. And so we're looking at very, very low levels, less than 5 liters per minute of cardiac output. And the drug treatment strategy is going to change. We're no longer using beta blockers. We're going to use beta and dopamine agonists. These are called positive inotropes. Remember, if you will, the beta blockers were defined as negative inotropes. Now we're going to switch gears and we're going to start treating with positive inotropes. Positive inotropes can also be described as phosphodiesterase inhibitors like milrinone. And then we'll still use with some slight reservation diuretics and vasodilators, and we'll start to include the vasopressin receptor antagonists, which are discussed elsewhere. So acute decompensated heart failure is going to be treated differently. And so another way you can think of systolic heart failure is systolic compensated heart failure. So those compensatory mechanisms that we talked about very early on in the pathophysiology introduction were the pharmacological targets. Now this is decompensated heart failure. Those compensatory mechanisms have been essentially turned off, and the patient's essentially progressing down a terminal type of fatal path. And so this needs to be adjusted very quickly and needs to be treated accordingly.